Hey everyone, welcome to the first REMO update podcast. My name is Mike Doyle. I'm one of the EMS fellows for the year, and I'm joined today by my co-fellow AJ Halstein.
Hello, everybody. My name is AJ Halstein. I'm here with Dr. Doyle today, and one of our goals of starting this podcast is just to go through updates that'll occur throughout the year with you guys to get it out to you in an easy and digestible way to learn about these updates.
So our first podcast today, we're going to discuss TXA. Our goal today is to get you more familiar with the medication, when to use it, learn a little bit about the mechanism, and I think a great way to do that is to start with a case. So I'm going to pass it over to AJ, who's going to introduce a case for you, and then we'll talk a little bit about the details.
All right. So the case we'll talk about is a 35-year-old male. You were called to the thruway for a witnessed rollover motor vehicle accident. On arrival, the patient's altered, but he's maintaining his airway. Positive seatbelt sign, abdominal tenderness. Initially, his vitals, his heart rate is 134, blood pressure is 86 on 48, respiratory rate of 26 with a pulse ox of 98%. Extrication was expected to be prolonged, so in that case, the paramedic on scene called for a physician to bring some blood product. The medic was able to start an IV and administer some TXA prior to our arrival.
All right, so this medic did a great job recognizing the signs of hemorrhagic shock, and so that's kind of where the TXA administration protocol comes from, is our hemorrhagic shock protocol in the New York State protocols. Under this protocol, it gives us some guidelines on when we should be administering TXA, right? So we're going to be using this hemorrhagic shock protocol when we expect somebody to be losing significant amounts of blood products or blood volume where they're going to become hypotensive from that blood loss. So specific to this protocol, under the paramedics section, it calls for the use of TXA with a couple of guidelines. First of all, we have to have a significant amount or expected significant blood loss, right? So that could be, in this case, a trauma, and specifically here we have somebody that has a positive seatbelt sign and abdominal tenderness. That would lead us to believe there may be an intraperitoneal or an intra-abdominal bleed. So that would be the first indication to enter this TXA protocol. The second one, though, is that we have to have signs of shock. And that can be multifold. Primarily, we're going to be looking at vital signs initially. So what's this patient's blood pressure? And the protocol states that if there's a systolic pressure that's less than 100, or a MAP, so a mean arterial pressure less than 65, that we should be considering administering TXA. As far as this signs of shock, that can be fairly broad. So I'll pass it over to AJ to discuss some more of these signs that we should be looking for on scene.
All right. So as Dr. Doyle was talking about before, the indication for TXA is signs of shock, in addition to the systolic blood pressure of less than 100 or the mean arterial pressure less than 65. Some of the signs that we're looking for to indicate shock: cool, clammy skin, mottled skin, you have weak and thready pulses, altered mentation could also be a sign. Another thing that you want to look at is the shock index. So you take your heart rate divided by the systolic blood pressure. If that's 1 or greater, you're definitely more concerned for shock. Now, we were talking about giving TXA. How does this work? How is this helping us in preventing life-threatening bleeding or decreasing morbidity and mortality? Well, it works by assisting our body in preventing thrombolysis, or the breaking down of clots that are already made. TXA doesn't cause clot formation, and the mechanism of action is by blocking the effects of an enzyme called plasmin, which break down clots.
So to echo what Dr. Halstein said, TXA, or tranexamic acid, is preventing the clot that your body's forming. It's helping to prevent that clot from being broken down. So again, to just be super clear with its mechanism, this is not forming a clot. This is not causing thrombosis or clot formation. It's just tipping the scales to say in the favor of clot formation and to prevent your body from breaking down that clot, which in turn is going to give you longer action of the clot that's being formed. So this leads to a question, right? If we're encouraging our body to form clots or to tip the scales towards clot formation, can that be harmful, right? So is this going to cause harmful coagulation, such as the things that we worry about, right? A DVT, a pulmonary embolism. Would it tip the scales towards a stroke or a STEMI, things like that? I'll pass it over to Dr. Halstein to discuss a little bit more what we know about the kind of downfalls or the side effects related to TXA administration.
All right, so that's actually a really good question. Like, why are we talking about this? Why are we having you guys do this? If you look at the CRASH 2 and CRASH 3 trials, it actually showed really good evidence that there's no increased risk of MIs, strokes, DVTs, or PEs versus the placebo. And then more specifically in the CRASH 3 trial, it shows that their TXA is beneficial in mild to moderate brain injuries, which they classify as a GCS of 9 to 14, or 15 rather. In severe head injuries, there's probably no real difference. Now I'm going to flip this to Dr. Doyle. Are we only using this for traumas? Is there any other protocols that say we can use this in other instances? Kind of tell me more about that.
All right, that's a great question. Of course, we have other types of bleeding outside of simple trauma cases. Some of the cases where we see significant hemorrhage somewhat regularly would be in the case of GI hemorrhage, so upper and lower GI bleeds. We also see it quite frequently in obstetrical or OB/GYN emergencies. The New York State protocols actually specifically states that TXA is indicated for obstetric hemorrhage. And so we're going to use this in essentially the same way that we would use TXA for trauma. If there's signs of shock, as Dr. Halstein discussed earlier, and we have vital sign abnormalities, and there's a massive hemorrhage from some obstetrical region, TXA would be indicated. As far as GI hemorrhage goes, our data is not as good to support the use of TXA in GI hemorrhage. In fact, there's some good data that shows there's probably not a benefit, and in fact, there may be some increased harm from giving TXA to GI bleed patients. Some people have hypothesized that this is because it's a very different population type. These are generally sicker patients. They may be older, they may have underlying disease, whereas the general trauma and obstetric patients generally are younger and healthier overall. So that's all to say that we certainly would encourage you to consider TXA in OB/GYN causes of hemorrhage in addition to just simple trauma cases. So now that we talked about other uses of TXA, I'm going to turn it back over to Dr. Halstein. I'm curious because recently, in July of this year, the protocol changed. And now instead of giving a 1 gram dose of TXA, we're giving 2 grams. Dr. Halstein, can you talk a little bit more about why that protocol changed?
Absolutely. So since there's so much research on TXA recently, there's been many studies that says that the 2 gram bolus over 10 minutes of TXA doesn't really change or isn't worse than giving the 1 gram than 1 gram. And in fact, some studies say it might actually be better. The reason why I think this was made and more beneficial is because when you give the 2 grams of TXA up front, you eliminate that second dose needing to be handed off to the hospital. And I think that's very beneficial. In addition, the sooner the patients get this TXA, the better the outcomes are showing. My final thought about TXA is that you should not delay your on-scene time for IV access and administration of TXA and or blood. This could absolutely be done en route to the hospital. But now let me turn it over to Dr. Doyle to kind of conclude this case.
All right, so let's circle back to the beginning of the podcast where we introduced a case. If you recall, this patient was involved in a high-speed motor vehicle accident, had a expected prolonged extrication, and was hypotensive. Upon EMS arrival, he was a little bit confused and had some cool and clammy skin. So while extrication was ongoing, the paramedics on scene were able to obtain IV access. They administered him 2 grams of TXA via about a 10-minute IV push. We were fortunate enough to have a physician that was able to arrive on scene with blood products. The patient received 2 units of low-titer O-positive blood. Afterwards, the patient seemed to improve. His vital signs got better. He had a MAP that was approaching 75, and his mental status improved. Fortunately, a short period of time later, the patient was extricated and was able to be transferred to the hospital, to the trauma center in the emergency department. He had a positive FAST exam indicating intraperitoneal free fluid. Given that he was stabilized with blood products pre-hospital, he was able to be taken to the CT scan for further imaging where they found a splenic injury. Because he responded well to blood products, he was able to be a candidate for embolization as opposed to an exploratory laparotomy, which saved the patient a major surgery. He recovered well and had no lasting deficits or morbidity associated with the injury. Okay, so in summary, let's just kind of review everything we talked about today. TXA, or tranexamic acid, is a medication that would be indicated in massive hemorrhage, both traumatic and obstetric hemorrhage, with signs of shock and hypoperfusion, such as hypotension with a systolic pressure less than 100, or a MAP that's less than 65. Remember, when we're giving this, we're giving 2 grams over a 10-minute IV push. We talked about how TXA works, and that it's tipping the scales of your body's coagulation cascade to favor clot formation. It's going to prevent your body from breaking down the clot that it's already making. And we've also discussed that there's very minimal side effects. In fact, it doesn't seem to increase the risk of any significant thrombotic events such as DVT or pulmonary embolism. So our plea today would be to consider TXA in all the cases that we mentioned earlier.
All right, everybody, thank you so much for listening to this little REMO podcast update. This is our first one, so let us know if you liked it. Go ahead and hit the like button. Reach out to us, tell us you liked it. We're kind of gauging to see if this is something we can continue to do. Again, thank you all, and see you on the next one.